Thank you all, and thanks for attending today. I'm delighted to welcome you to the 20th Judith Hoyer Lecture in Epilepsy, Children Are Different, Advances in Epilepsy Assessment, Treatment, and Outcomes. The Judith Hoyer Lecture in Epilepsy combines the discussion of state-of-the-art in a specific area of epilepsy and the impact it may have on patient care and patient outcomes. We are proud to partner with the National Institutes of Neurological Diseases and Stroke to present this annual session. We are also pleased to continue to make this lecture accessible to both professional and public audiences. To that end, for the 6th year, we are streaming a live webcast of this public lecture. So many more may listen live to the archived recordings afterwards. I want to acknowledge the support of the educational grants from ASI and Upshur Smith, and the support of the live web stream of this lecture by Jazz Pharmaceuticals. The AES Extraordinary Contributions Award is designated for those who have made exceptional contributions across multiple fronts, including science, education, leadership, and advocacy. This award is only presented when the board of directors determines there is a candidate whose accomplishments embody the spirit of the recognition. I am honored to present this award on the behalf of the AES board to Dr. George Ogeman. Dr. Ogeman is not able to be here with us in person, but he is watching on live stream, so we'll say hello to him virtually. We are very fortunate today to be joined by Dr. Ogeman's 2 sons, Jeffrey and Stephen, his daughter-in-law Elizabeth, and his grandson Will, who's a bioengineering PhD student at the University of Pennsylvania. So I invite you all to stand, please. Please join me, as you have, in congratulating Dr. Ogeman for receiving the 2022 Extraordinary Contributions Award. Thank you. Dr. Ogeman graduated from the University of Iowa with a summa cum laude BA and MD degrees. He moved on to an internship in Seattle, where he met Arthur Ward, a Penfield trainee who had a neurosurgical program with particular emphasis on epilepsy surgery. He was Dr. Ward's 8th resident. Dr. Ogeman then spent 2 years at the Surgical Neurological Branch of the NIH, where he refined the electrical stimulation mapping, or ESM technique, for functional localization. He joined the University of Washington's neurosurgical faculty, where he remained for the next 40 years, from 1964 to 2005. In the late 1960s, there was little epilepsy surgery done in the US. Neurosurgeons considered it an exotic activity, not part of standard practice or training. Dr. Ogeman changed this by being a voice for epilepsy surgery within neurosurgery and amongst the wider public. He established an early epilepsy surgery fellowship training program, and by showing with ESM substantial variability between patients in the localization of crucial language cortex, and allowed for wider, safe resection in epilepsy surgery that would avoid albicant cortex. When he retired, he had performed almost 1,000 therapeutic epilepsy surgeries, and epilepsy surgery was part of standard neurosurgical training. The long-term impact of his pioneering work on the lives of people with epilepsy is truly an extraordinary contribution. So I'm very pleased to now share with you Dr. Ogeman's recorded remarks.
I want to thank the American Epilepsy Society for the extraordinary contribution to fields of epilepsy honor. When I look back on my neurosurgical career, many of the patients whose lives improved had medically refractory epilepsy responding to focal cortical resections, guided by EEG and functional mapping findings. Yet when I started in practice, epilepsy surgery was infrequently performed in the United States and generally regarded by practicing neurosurgeons as an exotic procedure outside their specialty. I became a voice for the inclusion of epilepsy surgery in neurosurgical practice and training, so that both of my neurosurgical sons and many others now include it in their practices. Additionally, using modern electrical stimulation mapping and single neuronal recording, we had some new insights in the organization of language in this population, considerable variability in the location of essential cortex, and separate areas for different languages. Those insights reduced the risk of resections in these eloquent areas. In these studies, I had many collaborators, from medical students to well-established investigators in multiple disciplines. Some have had distinguished careers in epilepsy. I want to particularly acknowledge the late Arthur Ward, my mentor, who established the Epilepsy Center at the University of Washington, and from those who provided care in that center, my wife of 55 years, Dr. Linda Moretti-Ogeman.
Thank you. Thank you, Dr. Ogeman. Many thanks to you virtually, as I know you're watching, so thanks for your contributions. So I'd like to move on now to the Distinguished Service Award. The Distinguished Service Award was established in 1993 and recognizes outstanding service by an AES member in the field of epilepsy, with an emphasis on exemplary contributions in service to the American Epilepsy Society, its members, and our patients. I am most pleased to present the 2022 AES Distinguished Service Award to Dr. Samuel Wiebe. Dr. Wiebe obtained his MD degree from the University of Guadalajara in Mexico and specialized in internal medicine at the National University of Mexico. He trained in neurology, epilepsy, and electrophysiology at the University of Western Ontario, Canada, followed by a master's degree in clinical epidemiology and biostatistics at McMaster University, Canada. He served as director of the epilepsy program in Western University in London, Ontario, Canada, where he founded the evidence-based neurology training program. He became head of neurology and associate dean of clinical research at the Cummings School of Medicine, University of Calgary. He is currently director of the Calgary Comprehensive Epilepsy Program, professor of clinical neurosciences, and chair of the clinical research unit at the University of Calgary. He is a fellow of the Canadian Academy of Health Sciences. In the International League Against Epilepsy, he served as president of the Canadian League Against Epilepsy, chair of the ILEA North American Commission, and consecutively as Secretary General, Treasurer, and President of the ILEA. Notably, Dr. Wiebe, along with ILEA leadership colleagues, spearheaded the efforts that led to the ILEA adoption of the 10-year intersectorial global action plan on epilepsy and other neurological disorders. His academic interests include epilepsy surgery, health services and outcomes, and evidence-based medicine. He has published over 300 peer-reviewed articles and has given over 350 international lectures. Dr. Wiebe, please come join me at the podium to receive this well-deserved honor with our deepest thanks for your service. Congratulations, Sam. Yeah, yes, certainly. Please.
Just a few words. Thank you first to the American Epilepsy Society, to the awards committee for this great honor. All of us have been given the unique responsibility and privilege of looking after people who are afflicted by epilepsy. What an honor. It is said that at the end, we are all stories. And I would like to thank the countless people who devoted hours, efforts, and talent to help write this story. Thank you.
Congratulations, Sam. Well, next I'd like to say a few words about the AES Early Career Award Program. The core to the AES mission is development of the next generation of basic, translational, and clinical investigators. These young investigators are the future of our community, and they're a vital part of our society. AES encourages young investigators to attend the annual meeting by providing travel and other awards in recognition of the most outstanding abstract submissions. You can see the listing of these early career investigators in the awardee booklet, and I encourage you to visit their posters. In addition, AES supports research through more than $1 million in fellowship and grant awards. An example of partnership to ensure funding of early career investigators is the AES, American Brain Foundation, AAN, Epilepsy Foundation, Susan S. Spencer Clinical Research Training Scholarship in Epilepsy. Please join me in recognizing Dennis Spencer, who will introduce the 2021-2022 awardee. Dennis, please.
It is my great pleasure to introduce Dr. Samuel Turman from the University of Michigan. He shares that location with my daughter, who's in neuroendocrinology there, so it's, I guess the university's doing okay. Dr. Turman is an assistant professor in neurology at the University of Michigan. In his 2-year fellowship, he will be studying seizure risk prediction after anti-seizure medication discontinuation in patients with well-controlled epilepsy. Please join me in congratulating Dr. Turman on his prestigious award. The Susan S. Spencer Clinical Research Fellowship is made possible by the generous personal gifts of the AES member, and as we heard, the Epilepsy Foundation and the Academy, and all others who have made contributions to the endowment that supports this fellowship. Thanks to all of you who have been a part of this effort, and for everyone here. Just a reminder with my development hat on, it only takes a minute to support the Susan Spencer Fund and the Lilix and Lombroso Fund, the Hergievsky Fund for Epilepsy Health Equity and Diversity, and other AES research efforts and education programs. In fact, if you take out your phone right now and text AES to the number you see on the screen, you'll be on your way to helping AES support the career pathways of the next generation of researchers. AES, many of you have been asking about the seahorse pin. We have made many more of these seahorse pins this year. You can't buy these pins, but you can put a donation going up to the membership booth, a donation of $1,000 per year for 3 years, and you will find yourself owner of one of the seahorse pins. The seahorse pin, if you remember, is special because a seahorse pin that I gave to Susan many, many years ago was then modeled later on using the platinum single electrode contacts of many of our patients. So each one represents a patient that we have taken care of and a donation that you'll love to give. Thank you for supporting all of this important work. Ed?
Thank you, Dennis. Congratulations to Dr. Turman on this recognition for your research efforts. The AES is also is proud to be the administrative home as well as a member of the Epilepsy Leadership Council. To say a few words about the ELC, I would like to invite Amy Brin, chair of the ELC Steering Committee, to come to the podium. Amy, please.
Thank you, Dr. Hogan. I'd like to specifically thank you, the entire AES board, AES's Executive Director, Eileen Murray, and AES's manager, Ann Gramiak, for all of the support, collaboration, and professionalism that you continue to extend to the ELC. I'm happy to be here on behalf of the ELC. ELC stands for the Epilepsy Leadership Council and is made up of professional societies, nonprofit patient advocacy organizations, and federal agencies, all working together to expand our impact and improve the lives of individuals living with epilepsy. The slides you saw as you entered the hall showed some of the important work that the members of our ELC are doing. Many of the ELC members are also exhibiting in the Epilepsy Resource Center, and I encourage you to visit their booths to learn more about the important work that they are doing to support the lives of all people living with epilepsy. The ELC is one of the outgrowths of the 2012 Institute of Medicine's report, Epilepsy Across the Spectrum. I hope you'll join me and other ELC members on Sunday afternoon at a very special session, IOM NAM's 10th anniversary of Looking Back, Moving Forward, Next Steps on Epilepsy Across the Spectrum, to hear about the progress we've made towards the report's recommendations. I look forward to our continued collaboration and commitment to the people living with epilepsy. Thanks so much.
Thank you, Amy, and to the steering committee for your leadership of ELC. Well, there's one person left on the stage besides me, so it's a pleasure to introduce Dr. Walter Korshitz, Director of NINDS. Dr. Korshitz's presence reflects both a long history of a strong NINDS support for the epilepsy community, as well as his personal commitment to epilepsy research. And we sincerely appreciate his taking the time from a very busy schedule to be here with us again this year. So Walter, please come forward.
Who've been a physician.
Maybe add another accolade to Dr. George Ogerman, and that is maybe anything he had to do with his brother. His brother, Robert Ogerman, was a pioneer vascular neurosurgeon at Mass General, who I worked with for years. And I don't know who influenced who, but really, what an amazing duo. Well, it's my pleasure to introduce the 20th Annual Hoyer Lecture. And I just want to make a couple remarks to tell you a little bit about what's been going on at NINDS relevant to this meeting. Next slide. And I'm talking on behalf of the, I have the slides, of the, the program directors from NINDS who are here today, and they're here throughout the week to help you try to navigate what is a complicated system, but it's worth navigating because there's a lot of money at NINDS right now. So please talk to the program directors. So this is the 20th Judith Hoyer Lecture in Epilepsy, and this lecture is to talk to the public as well as a scientist about important findings in epilepsy. Judith Hoyer was instrumental in promoting research into better therapies and quality of life for people with epilepsy. She was on the board of directors of the Epilepsy Foundation. She spent her whole life particularly trying to improve the education of children and the quality of life of people with epilepsy. And she's the late wife of Steny Hoyer, the majority leader in Congress from the state of Maryland. So I love to come to this meeting because at this meeting, the mission of NINDS is reflected in all of the activities, and that goes from the very basic to the translational to the clinical science and clinical research. We're here to understand with our program staff what are the gaps, what are the public health needs in epilepsy that we can do better with. We're here to encourage people to enter the field, to train in clinical epilepsy research or basic epilepsy research. And we are here also to tell you that there are some pretty cool tools that have been developed to look at circuit disorders, epilepsy being, a preeminent circuit disorder. These tools coming out of the Brain Initiative, I think, have the opportunity to revolutionize how we look at epilepsy, and then communicating with stakeholders and getting feedback so that we can improve what we do at NINDS. So that's why we're here, and it's a really important meeting for us. I just want to jump to the the budget slide right away, just to let you know that NINDS has been really fortunate to have received increases on a fairly continuous basis since the end of the flattening in 2014. Right now, we don't have a budget. We're operating on a continuing resolution, so everything is kind of on a tightening budget situation until we know what our budget is. We have the House mark, the Senate mark, and we'll have to wait and see. We suspect that it actually may be a while before we know. We're under a continuing resolution until December 18th. But the budget has allowed, the increase in budget has allowed us to do a lot of great things, and I'll talk about some of these with regard to epilepsy. But just looking at the total epilepsy funding, which is really not reflected by any kind of top-down process, but it's at NINDS and NIH, it's a really American way in which anyone can submit a grant, get reviewed by their peers, and those who get the best scores get the funding, and that's what's driven the increase in epilepsy research, is really good applications from really good investigators in epilepsy. So you can see that the funding has increased from $138 million in 2015 to over $218 million in 2021. We don't yet have the official 22 numbers, but I'm sure they're going to be higher. And this funding has allowed us to do some really special projects. So most of our funding goes out, as I said, bottom up from what gets submitted. We have, with consultation with people at this meeting, the Benchmarks group set up a number of center projects. These are called Center Without Walls project. The most successful and the earliest one has been looking at the genetic determinants of epilepsy, and this is still ongoing. But there's also a new one now, which has been going on for a couple of years, looking at traumatic brain injury as a model to try and develop anti-epileptogenesis agents. So the thought is that people develop epilepsy after traumatic brain injury. There's this window of time where one could potentially intervene. So there's a large group of people working on this project at the moment. And these are just a couple of the articles that have come out looking at hippocampal damage after a traumatic brain injury. Turns out it wasn't related to the actual development of epilepsy, but it was related to cognitive impairment in the animals. And then also looking at the microbiome in people with traumatic brain injury. There, the finding was that the pre-injury microbiome was actually the one that was more associated with developing epilepsy than the post-injury. And then not related to traumatic brain injury, but another interesting avenue, which is looking with machine learning techniques at the rich data that comes out of, in this case, children who are being monitored with intracranial grids to try and find their epilepsy focus, and using those machine learning algorithms to look at signatures of high-frequency oscillations that are more related to epilepsy than others. So just a couple of tidbits from these groups. With regard to the genetic forms of epilepsy, there's two major groups working now. One is focused on channels. And in the first paper here, common risk variants, they looked at familial epilepsy, looked at common variants from GWAS studies, and were able to develop a risk score for epilepsy that differentiated people who were going to develop epilepsy from those who weren't in these families where there wasn't a monogenic cause. So we know monogenic causes account for a minority of epilepsy. The big group is still yet to be defined, but certainly there's evidence that these common risk variants are going to be drivers. The next one is looking at loss of function disorders due to deletions in monogenic genes that cause epilepsy. And there are many different phenotypes in some of these. Why do they have different phenotypes with the same gene being affected? This was looking at the fact that these deletions actually affect some neighboring genes as well, and that may actually be a cause of some of this phenotypic heterogeneity. The next one looking at mutations in NaV1.6 channels that cause epilepsy, and the finding was that calmodulin kinase 3, which phosphorylates this channel, can actually turn it back into normal function. So something from this group that may have therapeutic benefit. And then a really interesting project for me, having started out patch clamping cells with much frustration in the 1980s. This is a study where they looked at a particular potassium channel variant that causes epilepsy, but they use automatic patch clamping. So they're able to do thousands and thousands of patch clamps, which really got them into being able to show how the different mutations have different channels, have different properties, and actually respond differently to retigabine. So again, this kind of detailed analysis of the channels with potential therapeutic implications. We have another group that's looking at non-channel mutations. So they're looking at syntaxin binding protein 1. They're looking at protocadherin, and they're looking at the GABA transporter with multiple different projects trying to understand how these different mutations known to cause epilepsy, what the mechanism is, and potentially how to intervene. I jump now to the epilepsy screening program. As I mentioned, we fund basic science, and that's into basic mechanism of disease, basic channel physiology, but also translational science. So this program has been around for 40 years. Many of the drugs now on the market went through this program. It's like a factory of animals having seizures continuously, receiving multiple different meds to identify which meds are going to be helpful. And this is driven out of the University of Utah by Karen Wilcox. And the point is that this is free. It's free for people to submit their compounds and try and see if they work in these various epilepsy models. And we have a number of clinical trials on the clinical end, vigabatrin to try and prevent troubles in infants with tuberous sclerosis, a new study going on to optimize the dosing of midazolam in children with status epilepticus, and this is going to be done by the ambulance folks, the EMS group, and then the continuation of the maternal outcomes and neurodevelopment effects of anti-epileptic drugs by Kim and Page, which has been going on and providing value evidence on how to manage women during their pregnancy who have epilepsy. Lastly, we talk about the disparities, and we really want to concentrate on improving health equity in this country. That's a major focus at NIH right now. I know it is also for AES, but also around the world. So Ed Trevathan has a number of grants working in Africa where 70% of the kids with epilepsy do not get any treatment at all. So the global disparities, I don't know if people have been there, are just absolutely shocking, and so obviously seems so simple on how we could make a difference there, but it's never as simple as you would think. But Ed is really toiling away with his group. And I just wanted to say that the success of the CWOWs has Centers Without Walls for Epilepsy has encouraged us to start a team science project that can include epilepsy, but it can include everything else too. And this is really based on the success of the CWOW that we opened up this team science grant project for multiple people to put together a great team to approach a problem and try and solve that problem. And now it's my great pleasure to talk to you about William Gaillard, who's the Hoyer Lecturer today. He's a great friend of NIH, has been a great friend for many years. He's the Chief of the Division of Child Neurology at Children's National Hospital in DC, Professor of Neurology at Georgetown and George Washington, and he's going to talk to us about his work, most recently showing that if kids with focal cortical dysplasia are resistant to one drug, likely they're going to be pharmacoresistant to all, and so bring up the question of early epilepsy if you see that there is resistance even to one drug. So really looking to hear from Bill on this. And finally, I want to now let the video roll, and this is our annual message from the distinguished representative from Maryland, Steny Hoyer.
Hello, I'm Congressman Steny Hoyer from Maryland's 5th District and the Majority Leader in the House of Representatives. Welcome to the American Epilepsy Society's 2022 annual meeting. Epilepsy is a personal issue for so many people around the world. My wife Judy lived with epilepsy, and I saw firsthand the challenges that can come with this diagnosis. But I also saw all that one can accomplish and contribute while living with epilepsy. The AES annual meeting is so critical because it brings together epilepsy professionals in academia, clinical practice, industry, and advocacy from across the United States and, yes, around the world. By holding this meeting each year, we help ensure that we keep making progress so we can better understand, treat, and even cure epilepsy. The collaborative nature of the endeavor is very inspiring. The Epilepsy Leadership Council, for instance, is conducting a landscape analysis project to look at what we have all accomplished together in the last decade and what we ought to focus on moving forward. Additionally, nearly 200 epilepsy organizations recently sent a letter to President Biden urging increased investment in epilepsy research. Before I introduce this year's renowned speaker for the Judith Hoyer Keynote Lecture in Epilepsy, I would like to thank Dr. Walter Koroshetz for his leadership at the National Institute of Neurological Disorders and Stroke. Leading with knowledge, experience, and vision, Dr. Koroshetz has helped NINDS advance our understanding of epilepsy through projects like Center Without Walls program, the BRAIN Initiative, and the HEAL Initiative. I am very proud to continue working here in Congress to provide greater federal funding for medical research programs and services that support people with epilepsy and seizures, and that, hopefully, will lead to new treatments and cures. For fiscal year 2022, we increased funding for the NIH and the FDA, and we also increased funding for the VA's Epilepsy Center of Excellence program. I'm now working with my colleagues to expand funding for the CDC's epilepsy program in fiscal year 2023. This past year, we also enacted the Inflation Reduction Act, which will cap Medicare beneficiaries' out-of-pocket expenses for their prescription medications for the first time ever. This is critical to our shared mission, since more than 1 million people with epilepsy rely on Medicare. That groundbreaking legislation also extended tax credits to make ACA plans more affordable. We're also working to ensure that people with epilepsy can continue to access crucial healthcare services via telehealth. The House also passed a bill that will facilitate scientifically rigorous evidence-based research into medical cannabis and its potential to help treat resistant epilepsy. Ultimately, it is leaders like our keynote speaker today, William Gaillard, that give us hope. Dr. Gaillard is professor of pediatrics and neurology at George Washington University and a professor of neurology at Georgetown University. At the Children's National Medical Center here in Washington, D.C., he's the chief of neurology, epilepsy, and neurophysiology divisions, and serves as the director of Comprehensive Pediatric Epilepsy Program. If that weren't enough, he also serves as the President Emeritus of the American Epilepsy Society. In his lecture today, I know he will discuss his research on the effects of epilepsy, early brain injuries, and other developmental disorders on brain structure and function. Judy would be so grateful to see such talented individuals like Dr. Gaillard continue to make progress in the fight against epilepsy. And I know she would surely be proud to see this annual lecture in her memory continue to bring leaders together to build on the progress we've made. I look forward to continuing to play my part in that mission here on Capitol Hill. And I hope Dr. Gaillard's lecture and your collaboration at this year's meeting will help fuel your important work. Thank you. Thank you for all the work that you do that is changing the lives of millions and millions of people. Godspeed.
Pleasure to introduce Dr. Gaillard.
Loaded.
Concerned about the slides. Are we?
I'm about to act out my lecture.
Yeah.
Good morning, everyone. Thank you for joining us today. Thank you for the kind words and the introduction. It is an honor and a distinct pleasure to be here with you today. Thank you, Dr. Korshets, for your support, and also for Representative Hoyer for his support for research, for his many years of service in Congress. So I would like to let people know that I actually have combed my hair several times today. But but it's just so electrifying to be here, it just doesn't stay in place. So what I'm going to do today is talk about how children are somewhat different than adults in the expression of their epilepsy and also the prospects for treatment. I'm going to focus on two main areas that has to do in the setting of development and how children grow and mature, but the effect of early treatments on changing the trajectory of encephalopathy and their epilepsy, using two situations. One is focal epilepsy with surgery, and the other will have to do with personalized treatment for the genetic epilepsies. For those of you who are geneticists, I hope you are entertained by an imaging person presenting genetic understanding. There are disclosures to be had. The first disclosure will be, I would like to thank all of those of you who pay taxes for supporting the grant that NINDS has generously provided for us over the last many years. Also, foundations such as the Bound Foundation and PERC for supporting philanthropic support, and I also make clear and free acknowledgement that I use pharmaceutical and hotel pens with their logos. Okay. So is there any prospect of progress with my slides? Dr. Hogan has also agreed to act out some of my slides, and I was hoping to have a country music chorus in the background, but we could not arrange that.
Bill, I do my best, but I'm a little old for your cohort, I think.
No, you're young. You're young.
I am. Okay.
We all were children once.
All right. Yeah.
So everybody can stand up and stretch if they would like. This may be the briefest Hoyer lecture in history. Well, we'll give people a few more minutes, and then I will. Many years ago, I don't know if anyone knew Dr. Pincus, who was at Yale for many years and then chairman of neurology at Georgetown for years before going to the VA. And we asked him when he was in his mid-80s to give us a lecture from his early work in behavioral neurology. He came diligently, and of course our audiovisual system completely collapsed, and he had no slides whatsoever. And he gave one of the finest talks I've ever heard in the complete absence of any slides or materials. I've always maintained if you can't give an imaging talk without slides, you're not worth your salt. So.
It's like signs of life.
Live? Do we have any signs from anybody?
Maybe, maybe a comment that
Yeah.
Steve Jobs used to have a trick where he'd make people present without their slides to say they really knew what they were talking about. But you've covered that.
But I don't know what I'm talking about. So as you will know, I'm a childish neurologist, and I take care of children. And children are not small adults. And there are some distinguishing features in epilepsy in children that are different from adults. I'm supposed to tell you what the educational objectives are. One is to understand the differences between adults and children in epilepsy. The other is to appreciate the criteria for and effects of epilepsy surgery in children. And the third is to have some appreciation for personalized medicine that's coming down along the line. So then the issue is, why children? Because most epilepsy, in fact, begins in childhood. You are all familiar with Alan Hauser's very elegant studies of epidemiology and several other of his colleagues. And while there is a large amount of epilepsy that begins after the age of 65, I'm a pediatrician. And the large bulk of epilepsy begins before the age of 5, and actually most of it begins before the age of 3. So if you are in the business of trying to provide someone a life, then it is worth placing your efforts on trying to understand the early life epilepsies, how they occur, and to provide interventions. Aha! Whoa! There we go. So that's me. You should appreciate that we didn't have eyeballs in our logo for many years. Now George Washington and the bear have eyeballs. So we've talked about my disclosures, and we talked about our learning objectives, and this is the talk. So I've already talked about age and epidemiology. Then I'm going to talk about some unique considerations in children. And because my area has been in imaging cognitive systems during development, we're going to talk about that because that is one of the unique features of childhood. And the development of these systems has impact on comorbidities, and it is relevant to when you are able or should intervene, at least surgically, in children. I will then talk about epilepsy surgery to cure, and I will end with some brief discussion on developmental and epileptic encephalopathy and personalized treatment. This is the Alan Hauser slide. So let's talk a little bit about the expression of encephalopathy and IDD and maturation in children depends on the etiology, the epilepsy, and the treatment. There are unique features in children. There are age-specific epilepsy syndromes and etiologies. And for all of the adult neurologists in this room, you will remember how much fun you had on the pediatric epilepsy service. Brain development, which is a topic of this talk, and the prospect for plasticity and recovery of function. And I will show really some quite striking data from children with perinatal stroke. Developmental and epileptic encephalopathy may be mitigated and reversible. We'll talk about genetic epilepsy and new therapies, and also how focal epilepsy and surgery may partake in that role. So this is a slide pinched from Case Braun, just showing a general normal developmental trajectory, and then perhaps a developmental trajectory of a child with IDD due to the etiology of the epilepsy, not the epilepsy itself. And then there's the component of the encephalopathy that is induced by the seizures, which is the epileptic part of the encephalopathy. And that if you are able to intervene, here he uses surgery, but this can be any other intervention, then you may be able to partially reverse the epileptic portion of the encephalopathy. You may be able to completely reverse it, or at least to mitigate it. I would argue with upcoming therapy, not with surgery, that you may actually be able to alter the trajectory of the epileptic pathology and normalize that. I think that is in our future. That's the arrow. Okay, here we go. With parachutes. You know, there are no studies that demonstrate that parachutes are effective. Okay, so we're going to talk about developmental consolidation of cognitive systems. Many systems are lateralized, such as language and visual motor function. And these lateralized systems begin with bilateral representation, and they become unilateral. And if injured, these systems can transfer to the other side of the brain. And if one does not transfer them, you tend to be more impaired in these spheres. And that paradoxically, those systems which are bilaterally represented generally yield a little bit less compensation, for example, executive function. It is an axiom of pediatric neurology that global insults are really very bad, and that acute focal injury is much better sustained and tolerated. I will spend some time on language memory and visual spatial systems, and we will talk about these being mapped by functional MRI. How many people have seen X-Men? No one's seen X-Men? This is Magneto in operation. Okay. In the lower right-hand corner is going to be a picture of the people who did all the work, at least for us. So this is a task that we use for functional MRI. It is a word decision task, which is auditory. For example, a long yellow fruit is a banana is true, and a pink bird is an elephant is false. And this task is highly effective in identifying language systems in the anterior and the posterior regions of language processing. They are highly lateralized to the left hemisphere for most people, and they are regionally specific. So this is going to be the task we use to discuss a variety of things. These are data looking at these maps in age groups from 4 through Georgetown undergraduates and graduate students, and you may debate whether or not that's a legitimate population or not. However, as time occurs, you will see that the activation is diminished on the right side of the brain and is more focused and concentrated on the left side of the brain with age. And in fact, the age at which you establish really dominance in the receptive language areas in the temporal lobe is around the age of 6, and for frontal lobe, it's around the age of 10. And that, of course, is important for other considerations. So this is work that was conducted with our colleagues at NIH. A bunch of controls evenly split between adults and children, and also patients evenly split between adults and children, about 2/3 of which have a left focus and 1/3 of which have a right focus. And in the right-hand side, you can see that most people, looking at Wernicke's and Broca's area, are very highly lateralized to the left. How many people here are right-handed? How many people here are left-handed? How many people who are left-handed raise their right hand? Okay. So most people who are right-handed are left hemisphere dominant for language, and most people who are left-handed are as well. And this is demonstrated here in this graph with all the little blue circles in the upper right-hand corner. In contrast, patients with focal epilepsy have a much greater variability in their expression of language dominance and language processing, shown in the left-hand slide. While most people remain in the upper right-hand corner, others are scattered all over the place, and there's no one single pattern which remains. In fact, it is really highly variable and depends on several factors. So when one looks at this, approximately 1/4 of our patients exhibit some form of atypical language dominance compared to 3.5% of controls. And this is very similar to the very elegant studies that were done by Rasmussen and Milner at the MNI using the WADA test in the 1960s and 70s. The earlier age of epilepsy onset is associated with atypical language representation, and it is usual that the etiology for the epilepsy or the epilepsy onset occurs before the age of 6. You really don't see this after the age of 6 unless you really are getting the normal variation that you would expect in the 3.5% of controls. That atypical dominance of Wernicke's lateralization is associated with early seizure onset, but not atypical representation of Broca's lateralization, which tends to follow language handedness. And we believe this reflects the differences in regional brain maturation, both structural and functional. Of course, you can't have functional changes without structural maturation as well. Okay. There are limits to the extent to which language systems can be, quote, reorganized. And these are from data-driven studies. And the summary here is you get interhemispheric reorganization is restricted to right homologs, when you have things occur before the age of 6, and you have within hemispheric compensation, usually after the age of 6, and that is restricted to the margins of the language processing areas. It doesn't go all over the place, which some people have hypothesized in the past. So there's a limit. When you look at memory studies, as Dr. Cepeda has done. Here we are looking at verbal memory activation in our language processing task. And for adults, the activation of the hippocampus follows a language dominance. But in the children in the pediatric group, it is much more bilaterally represented. It does not follow language dominance. This suggests the possibility that material specificity that occurs with episodic memory systems does not mature until the teenage years, which is the object of her K23 award, which was initially supported by the Spencer Award. So thank you. Okay, we're going to talk about this task in the Perinatal Stroke Project. So this is a group of teenagers and young adults who had perinatal stroke, that is at the time of birth or before birth, and in the left MCA and the right MCA or MCA plus territory. And these are their activation maps. The controls are siblings, so we have then controlled for a variety of other factors that might influence how one does with these things. And you can see where the strokes are, it's pretty obvious. Those would be the holes. And the activation, which is red. And you can see, although it's better on the next slide, that if you have a left MCA stroke and you can talk, language has moved, and it's moved to homologs on the right. So here are the group maps. Left is left and right is right. I'm a neurologist, I'm not a radiologist. And those with a right MCA stroke have activation where you would expect, and those with a left MCA stroke have activation in absolute homologs to what you would expect for the normal controls, which are the siblings shown in the middle. For both of the patient groups, right or left MCA stroke, the activation is less in extent and in magnitude. And this is likely because there is not crowding. When you look at the IQ of the controls, and this is a little bit of an above normal population, compared to those with stroke, either right or left, the IQs are lower in those who have had strokes. If you have epilepsy on top of your stroke, your IQ is a little bit lower than what you see here. So epilepsy is not good for you on top of your structural, acute, and chronic injury. If you look at the brief, which is a measure of executive function, and here a higher number is more executive dysfunction, those with stroke have much more higher scores of executive dysfunction. And in fact, if you go back to this, the decrease in IQ can be explained by the differences in the brief, because you require executive function to do most of the testing in an IQ test. So the IQ test here is in part a measure of executive function. And if you look at language scores on the self-basic language abilities or the TROG2 comprehension of syntax that eliminates executive function as part of the task, you find there is absolutely no change in language measures if you have a right or a left MCA stroke compared to your siblings. This is astounding. If you have a stroke that knocks out 1/2 of your dominant hemisphere, you have no differences in language function when you are a teenager or an adult. There is complete recovery of function. It is moved to the other hemisphere. This does not happen to adults. So when you get that first thing about how adults and children are different, this is one of them. Okay. This is also true for line bisection. So this is a right parietal task. And as you will see in the next slide, this has a similar age trajectory of maturation as does expressive language in Broca's area, shown here in the group and an individual. And the young children are bilateral, the older children are lateralized. And if for those with the right hemisphere stroke, they have moved to homologs in the left. And this is just a slide to show the developmental maturation of the laterality of this function, again, reaching adult levels at around the age of 10. Okay. So there is hemispheric specialization with age and maturation of some functions, such as language, memory, and some visual spatial tasks. And they are more bilateral in younger children. That what we call reorganization, which I would maintain is developmental persistence, goes to the homologs with early insult and the edges with later insult. There is absence of crowding in our studies, which I've not shown, and the bilateral systems have less capacity for full recovery, hence the lower executive function scores. So vision is vision, and that never reorganizes or changes. Motor control is also established very early in fetal development. And those with a perinatal stroke or stroke up to the age of 2 will have a helping hand in their paretic hemisphere, but they will never have digitary control. Language, as we have said, matures between the ages of 6 and 10. Visual-spatial at 10. We believe that memory material specificity is in the later childhood to teen years. And that unilateral systems can transfer, but bilateral systems do not. And this, of course, has obvious implications for the timing of epilepsy surgery, as one can be more aggressive in younger children because there will be recovery of function if that needs to be, if that is in the area of the resection if necessary. Is everybody good with that? Okay, so in the setting of early brain injury, there is persistence of immature patterns. That reorganization, I think, comes from the persistence of these developmental patterns. I think during development, these areas are suppressed by inputs from homologous regions across the corpus callosum. Okay, now we're going to move to epilepsy surgery for the young. Okay. I would like to thank the New Yorker for pilfering their slides for this talk. Okay. So I'm going to give mostly summary slides at the beginning and then show the slides that go along that would support my statements. So early life epilepsy and epileptic encephalopathy. So focal epilepsies, which begin early in life, where some, but not all, are a progressive disease. You will know that unlike adults, in children, about 2/3 of children do well. And really I'm focusing on the 1/3 of children who don't do so well. Outcomes in children are different. Early surgical interventions are likely to lead to better outcomes. Deficits can occur if planned, but new deficits are unlikely when surgery is performed. And I would argue that for many, surgery treatment is the treatment of choice. It should not be the treatment of last resort. So again, for most, epilepsy begins in early childhood. Cognitive capacity can deteriorate. Again, for those who are uncontrolled with their medications, which is about 1/3, normal socialization is impaired. Quality of life may be poor. There is less independent living and less employment when people reach maturity. Epilepsy is deadly. Accidental drowning, suicide is 5 times more likely than the normal population. Sudden, unexpected death occurs in 1 per 100 patient years, and the cumulative risk once you get to 40 is 7 to 12%. And for those with early onset epilepsy before the age of 3 months, the rate of death is closer to 3%. That's bad. So for epilepsy surgery, for those with focal epilepsy, surgical outcomes are superior to medical management. The short-term outcomes that people report for their own work is between 70 and 90% seizure freedom. Long-term outcomes, at least in older populations, are 50 to 60%, but the long-term outcomes in early childhood surgery are not known and not established. But medical management achieves seizure freedom in about 3 to 8% of patients. Delay in surgery appears to be associated with less good seizure outcomes and earlier operation better outcomes. Importantly, one can identify in early imaging those people who are likely to benefit from early surgery, so 10% of imaging will be abnormal, and identify potential surgical candidates at epilepsy onset. And as Dr. Koroshetz showed, focal cortical dysplasia in children, the failure of one medication is linked to pharmacoresistance. So the risk of cognitive decline is low. The prospect of long-term benefit gain is present, and I think there is little to lose to consider epilepsy surgery. Now you know how I really feel. Okay. So if you look at infants and epileptic encephalopathy, so these are children less than 36 months, there is really little data on infantile surgery in this group. Those studies which do exist report a 60 to 80% seizure freedom depending on the pathology. These children are no worse postoperatively. Those who are seizure-free do better socially and developmentally than those who are not seizure-free. And the data from Japan on those with heavy megalencephaly would indicate that each month of uncontrolled seizures is associated with a linear drop in developmental quotient outcome. That is not good. And there are costs to uncontrolled seizures that can be catastrophic. This is an unfortunate child with heavy megalencephaly who experienced high output cardiac failure because of status epilepticus that resulted in a global hypoxic ischemic injury on top of the hemimegalencephaly. So if you do imaging at the onset of seizures or the onset of epilepsy with a high-resolution epilepsy protocol, even in those who are less than 3, where the imaging is not because of maturation, you don't see everything you need. You find abnormalities in about 40% of those you image. And of those, about 1/4 are relevant to the etiology and to the prognosis. And you identify 10% of patients who are potentially amenable to epilepsy surgery. You find cortical dysplasia, malformations of cortical development, and perinatal stroke. So then one performs epilepsy surgery to cure. This can be a focal resection of an abnormality. It can be a lobectomy. It can be a multilobar resection, which is more common in younger children, certainly less so in adults, and also unique to to children is hemispherectomy. That can be anatomic or a disconnection. That is where you remove half the brain. I spent 90 minutes with an insurance company when I was a house officer to get approval for a hemispherectomy. After 90 minutes, I was told the procedure would be allowed, but if it didn't work, they weren't going to approve another one. Okay. Epilepsy surgery is safe. If you look at the ILAE 2007 follow-up from the 2004 epilepsy surgery survey, of 1,000 cases, there were 2 perioperative deaths. If you look at the current PERC epilepsy surgery database of 875 operative cases, there are no perioperative deaths, including those who were operated on less than 36. There is another recent study looking at epilepsy surgery in those less than 3 months of age, which is really a very difficult population to operate on. It's like operating on Jell-O. And in really skilled hands, there are no perioperative deaths. As you know from Dr. Wiebe sitting in the front row, in the medical arm of their randomized trial, 1 patient died, although the surgical group also has some morbidity but not mortality. And one would reiterate that one really needs, especially in the young, skilled hands and a team, so the ILAE has pediatric epilepsy surgery centers, and again, especially if you're less than 24 months. That's the only thing everyone agreed on. So this is from the 2004 Pediatric Epilepsy Surgery Survey. These numbers still hold more or less. In the upper right-hand corner are the images of the most common abnormalities. So focal cortical dysplasia and malformation of cortical development is the most common in over 40%, brain tumors in 20%, stroke in 10%. Mesial temporal sclerosis continues to decline in pediatric epilepsy surgeries. It's very hard to find vanilla MTS anymore. I would postulate because of the use of rescue medications in febrile status epilepticus. Then the pediatric specific syndromes such as tuberous sclerosis, hypothalamic hamartoma, and Rasmussen's, and Sturge-Weber really have not changed all that much, although one would think the TSC numbers have increased since then. Many will know this scale, but not everybody will. So these are the Engel criteria from the Palm Desert meeting in the 1980s. 1 is free of disabling seizures, 2 is rare disabling seizures, 3 is worthwhile improvement, and 4 is no improvement. And these are data from the 2004 survey of the 1,000 cases. And what I would like to point out here is if you have an abnormal MRI, and I remind you this is a 1.5 Tesla MRI, and you completely remove the abnormality, the likelihood of achieving seizure freedom is about 85%. If you have an incomplete resection of an abnormality, then the outcome is not so good. If your MRI is normal, then the outcomes are less good. This is my favorite part. If you have a complete resection of what you can't see, your likelihood of seizure freedom is 60%. And if you have an incomplete resection of what you can't see, seizure freedom is 3%. And what that means is the MRI may be normal, but additional studies such as FDG PET, which is interictal, ictal SPECT, or source localization with MEG or EG Curie, if you have focal abnormalities on either of those studies, then you raise your likelihood of achieving seizure freedom for around 50 to 60% in conjunction with invasive EEG studies. So that's what that means. But the point is, if you have a lesion and you take it out, the likelihood of seizure success is pretty good. So Dr. Perry has put together the Pediatric Epilepsy Research Consortium Epilepsy Surgery Group. It's got 23 centers. He's got over 500 to 800 children. The 2 slides are somewhat different in their numbers. The age of onset of epilepsy is 5.6 years, remembering that most people begin before the age of 3, right? And the age at surgery here is 11. If you look at adult series, the age of seizure onset now is about 13, and the age of epilepsy surgery is in the 30s. So this is a delay of 5 years, but better than our adult colleagues. Sorry, adult colleagues. The number of medicines prior to surgery is about 3.5, and he's got a whole list of surgery types, etiology, and pathology, which are on this slide. But what I would like to bring out to you is what is in red. And that is, if you are less than 34 months, there are 34 children in this database who have had an operation. And I mind you, these series are extraordinarily limited. This is the largest series of its kind in this group. Almost all had an abnormal MRI. 1/3 had a hemispherectomy, and 2/3 had either a focal resection or a lobectomy. And of these, 60% were seizure-free. And I would remind you that when you're talking in this age group, you're not talking about 3 seizures a year. These are mostly children with daily seizures, multiple daily seizures, at the very least weekly seizures. It's a very bad position to be in. There are mounting evidence that delays in surgery may reduce the likelihood of achieving surgical freedom. This kind of brings up the concept of what kindling may do. There is also evidence that if you achieve seizure freedom and you discontinue your anti-seizure medications, this is associated with better cognitive outcomes. You also have to be persistent. So at least in our center, repeat surgery occurs in 10 to 20% of patients. And even when you reoperate, your likelihood of achieving seizure freedom is about 60 to 65%. So if you want to achieve seizure freedom, you have to be persistent. There we go. This is the European study. This is lots of people, children and adults with different pathology, looking at the likelihood of achieving seizure freedom with duration of epilepsy across time, showing there is a steady decline in likelihood of achieving seizure freedom with delays in surgery. It's also a very nice color graph. This is from the MELD project from University College of London. This has about 17 centers. This is restricted to focal cortical dysplasia, shown in their distribution in this map, and showing that the delays in surgery are also associated with a linear decline in likelihood of achieving seizure freedom. So the longer you wait to operate, the less likely you are to achieve seizure freedom. And this is not a selection bias of epilepsy severity. Interestingly, the outcomes are superior if you have a 3 Tesla scanner than a 1.5 Tesla scanner, and I suspect that may also be the case with 7 Tesla scanners. And there's also some distinction in different histology, which you can see in the lower right-hand corner. And this is, you've already seen this slide before. Thank you, Dr. Korsetz. So this is work from Nate Cohen, who is one of our wonderful junior faculty. So he looked at our group of those with focal cortical dysplasia, of whom about 25 to about a quarter to a third are seizure-free or are controlled on medications. So not everyone with a dysplasia is refractory, although they may be when they're 20. And of those who had surgery, 72% were seizure-free. And the definition of pharmacoresistance here is a standard ILAE definition, the failure of 2. And notice the children don't fail the medications fail the child, right? So 2 medications that have been used in appropriate doses that are not associated with an intolerable side effect early in the dosing that have not controlled the child's seizures. So for those who had surgery, 72% were seizure-free. But if one medication failed the child, the odds of the next medication controlling the epilepsy was astoundingly low. And really, operationally, this meets the criteria for failure of a medication. So after one medication has failed the child, you effectively meet the criteria for pharmacoresistance. And one would advocate and argue that you should then operate after 1 seizure medication has been failed, not 2. There's no reason for the additional delay, especially when the epilepsy control with surgery is so high. Okay. I would like to take a brief digression on focal cortical dysplasias and their somatic mutations that are associated with them. Somatic mutations mostly occur in the ventricular zone and alter migration and organization of their daughter neurons. This gives you the wedge-shaped approach, which you'll see in the next slide. I would also argue from recent evidence from Melbourne that somatic mutations may involve channelopathies and may be harbored in the distribution of their daughter cell migration, and that may explain some MRI and pathology-negative focal cortical dysplasia. So as you will recall from 10th grade biology or from medical school, the cortex evolves inside out from radial migration from the ventricular zone, and if you have a mutation in one of the daughter cells, then that wedge shape of that distribution results in a focal cortical dysplasia. Here in the lower right-hand corner is the triangular shaped or wedge-shaped abnormality of a type 2B focal cortical dysplasia. And the interneurons often come from horizontal migration of neurons from the thalamic eminence. But the point here is that there is mounting evidence that the somatic mutations that occur in the parent cell involve the mTOR pathway. And the TSC genes are well known, but there are several other genes in the mTOR pathway that may be affected that may result in abnormal neurons and abnormal neuronal excitability and result in refractory epilepsy. Whereas the genes in the type 1 dysplasias, which are mostly columnar organization rather than pathologic abnormalities in neurons, involve a different set of genes which have not yet been as well delineated as those in the type 2 dysplasias. And from Mike Hildebrandt in Melbourne, this is really cool. So this is a person with a normal MRI and refractory focal epilepsy who had stereo EEG to identify the seizure focus. And they recovered the neurons from the tips of the stereo EEG wires and then expressed the gene profile in those neurons, identifying a KCNT1 somatic stop-gain mutation from the SEG probe that showed a mosaic gradient, as shown here in the blue, red, and orange. And that effectively is a wedge-shaped appearance, and that would suggest that you can have a mutation in a channelopathy, in a channel expression that results in effectively a focal channelopathy that results in focal epilepsy. I think that's pretty cool. Okay, so we've talked about surgery, we've talked about how wonderful it is, we've talked about the low risk of surgery, but we have not talked about cognitive outcomes. So unlike adults, new cognitive deficits are unusual, even with a hemispherectomy. Most children show no change in cognitive function. The large majority of children function within the same developmental category, but it's highly unlikely or unusual to be worse. Some, those who are fortunate, may have improved measures, especially in social domains, if seizure-free and with time. Sometimes we will plan or accept weakness or a field cut, but we will never accept aphasia or amnesia to achieve seizure control. However, if you're operating on those less than 6 years, that's not an issue because the children will reorganize, as we have seen. So this is the very elegant work. I hadn't realized each line is a push button from Mary Lou Smith in her work at Toronto 6 Children's over the last 2 decades, looking at children who undergo epilepsy surgery compared to those children with medically refractory epilepsy who have not undergone surgery. And what she finds is there's no change from baseline to short-term follow-up. There is eventual improvement for some who are seizure-free in full-scale IQ, the seizure-free advantage in VIQ at long-term follow-up. The main finding is if you are seizure-free, you have higher scores on working memory and processing speed, and the most marked improvement shown in the lower right-hand corner in the really small text is in social behavior. So really no difference in cognition, some mild benefits for some IQ and working memory, but the most improvements are in social behavior with seizure freedom. That's not to say that you can't have deficits in children. So these are 2 studies with somewhat different results. This is her work on looking at temporal resections in children. The mean age of surgery here is 12 or 13, really showing no difference. But if you have a mesial resection of the dominant hippocampus, you may get impaired wordless verbal memory measures in this population. That needs to be further explored. And I don't know what the data are in children who were operated on less than 10. But no person was amnestic, which is unlike what may happen in adults. And this is work from Great Ormond Street showing that with temporal lobectomy, there really were no changes. There were improvements with time. Memory on the other side seems to improve. And if you look at over time, there are gradual improvements in memory scores in these children. So with time, children do better with recovery than adults would, according to these data. Okay, so now looking at hemispherectomy. There are 2 or 3 studies looking at large resections in children. So the etiologic substrates for hemispherectomy are Rasmussen's encephalitis. So these kids are older, they tend to have more cognitive deficits following surgery. Those with perinatal stroke, hemimegalencephaly, and diffuse cortical dysplasia. And remarkably, when you operate, there really, except maybe a little bit in the Rasmussen's group, there is no change in IQ measures. And when you look below, also at different pathologies, those with stroke really don't have any differences. They never get declines. They mostly get benefits or no change at all. A few children will have some mild decreases in measures, but most are unchanged, and equal fraction are improved. This is also reiterated in studies from UCLA, showing effectively looking at this is early onset in infants, showing no change in the developmental quotient for those who are operated on pre and post-operatively, and in fact that those who are seizure-free have a little bit mild increase in bump in their Vineland score post-operatively. Okay, so if you look at the time to stop study, which is a multi-site European study involving the United Kingdom, involving 8 countries and 766 children and 300 with pre and post-op neuropsychologic testing, there is an increase in post-operative IQ-related reduction with discontinuation of anti-seizure medications. And in fact, you can get many of these children off their medications within 6 months of epilepsy surgery. And if you do so, there is a long-term improvement in cognitive measures, which was also shown in both the Sick Kids at Toronto and the Great Ormond Street study looking with reduction in medications are associated with better cognitive outcomes. So getting off medications is good. There are some caveats. Most of these studies are retrospective outcome, so the success is likely overstated. But regardless, it seems to be better than anti-seizure medications. It is also possible that, especially for the younger children, those less than 3, where maturation has not been made in terms of brain structure, you don't appreciate the existence or the extent of the focal cord dysplasia, so you may underestimate that or under-identify patients. Repeat surgery, as I have said, is necessary to achieve seizure freedom in a minority of patients, but should be pursued. We do not know the long-term seizure freedom for early epilepsy surgery, and we do not have the long-term cognitive, behavioral, and quality of life and developmental outcomes, especially in those who were operated on before the age of 3 or 5. The Bailey, the Vineland, the developmental quotient, and the IQ are inadequate measures to get an assessment for higher order cognitive function, which is so necessary for living in our society. Also, the range of complications is not delineated. We only have operative mortality, which, as I've said, is extraordinarily low, but we don't have the other complications. This does raise the question that if you have an encephalopathy and you have an abnormal MRI and you have a horridly abnormal EEG, but you don't have clinical seizures, do you operate early to remove the encephalopathy? And I think that discussion is with us. Okay, so this is an imaging view of epileptic encephalopathies from the genetic point of view. So I would like to thank my genetic colleagues for their patience and tolerance and trying to educate me. So last look, genetic etiologies were common in about 35 to 40% of patients, especially younger, with new onset epilepsy. It is important that these data now should allow us insights into the pathophysiologic mechanisms and the phenotypic expression of the disease. We are on the verge in the world that novel treatments beyond targeted therapy to a receptor or neurotransmitter release and uptake are upon us. We now have the ability to target some pathways, and gene therapy is evolving and has begun. And I would also offer, as I did at the onset of this talk, that we have the prospect that encephalopathy can be reversed beyond treatment of seizures by targeting disease-causing mechanisms. That is part of our holy grail as pediatricians, and perhaps as adult neurologists too. Okay. So as I have mentioned, the epilepsy may be severe, and the encephalopathy may be severe, and there is the role of the gene, there is the role of the epilepsy, and again, medications sometimes, although mostly our friends, are not always our friends. There is a growing list of targeted anti-seizure medications to use or to avoid in specific genetic syndromes. And we talked about the prospects for targeted gene therapy, and again, I would argue that, that developmental delays may be reversible, not irreversible. This is a short list, it is by no means complete, of some of the channelopathies and genetic etiologies that indicate medications that should be used or should be avoided. Most of the people in this room will know about avoiding sodium channel blockers in Dravet syndrome and the use of valproate or fenfluramine in this population, and those with the GLUT1 transporter, the ketogenic diet. But what I would highlight is the tuberous sclerosis complex. Everolimus, which is targeted at the mTOR pathway, shows some reduction in epilepsy. It is not great, but it is a beginning. And we can learn from our oncology colleagues that targeting pathways with effort and time may yield improving results in this sphere. Okay. Did everyone like the small text? Good. Okay. Okay, so if you're going to go after targeted therapies, it would be helpful to have a knowledge about underlying genetic mechanisms. And there are different levels of complexity. So which cell types are affected? The inhibitory neurons, the excitatory neurons, the non-neurons, expression of specific brain regions. Is it a gain of function? Is it a loss of function? Are there, hold on. You know what? Here we go. Or are there downstream effects? The protein, the neuronal phenotype, or the effect on a neuronal network. And different variant types in the same gene can be associated with very different phenotypes. So for example, depending, for example, on SCN1A, SCN2A, you can either have epilepsy or autism depending on the type of mutation you have. And those really are quite different. So here is my Toyota model of epilepsy. So on the right is the SCN1A mutation of Dravet syndrome. This is where the brakes fail. This is the Prius. So the expression of the SCN1A genes is on the interneuron. And when the interneuron does not work, the brakes do not work. And if you give this child sodium channel blockers to make this work even less well, then you get worse off, which is why you do not use sodium channel blockers in these children. In contrast, the SCN8A mutations are on the axon helix in the outflow neurons. And these are a gain of function as opposed to the loss of function. So this is where the accelerator gets stuck, which is what happened to the Camry. So when you have a stuck accelerator in the output of the sodium channels at the axon helix, you have hyperexcitability. And in this setting, you want to use lots of sodium channel blockers at very high dose to control the epilepsy. So type of receptor, location of receptor, gain of function, loss of function. Okay, so this gets us to our last slides. And this is a brief discussion on the ongoing trial for Dravet syndrome using antisense oligonucleotides. So there is a natural mechanism for controlling expression of the SCN1A receptor, the natural antisense NAT. And antisense oligonucleotides bind to RNA, and they prevent the expression of a protein which may be abnormal, which may gum up function, but they may also be used to suppress those genes, which will then suppress the expression of other genes that may be helpful in the setting for that child. So the ASO in Dravet is designed to block the natural antisense and increase SCN1A sodium channel expression. And the increased expression of that gene reduces seizures in mice and non-human primates. And we will know soon whether it does the same in human primates. This is intrathecal dosing in a mouse model, and I've said the human trial has been ongoing for nearly a year. So if you inject this in a dose-dependent fashion, then what you see is you see an increase in mRNA of the sodium V1.1 protein expression, shown here in the lovely red lines. Aren't you excited by these kinetic studies? Okay. And a single injection reduces SUDEP, because these Dravet mice die from SUDEP. Very high and very early. And this prevents SUDEP in this model, as shown here in the red line from death and the black line with the vehicle. And finally, if you look at a single injection at the same time, it reduces seizures and prolonged latency to the first seizure in the Dravet syndrome mice, shown here in these two slides, with the red being the Dravet and the dark being the vehicle. So these are evidence to suggest in this animal model, and this is why animal models are important, that the use of this ASO targeted to improve and increase the expression of the sodium channel that is impaired by Dravet may increase the expression of the disease, may decrease death, and lower the seizure frequency. And we will know soon whether this is true in humans, and more importantly, we will know whether or not this not only controls the seizures, but will also affect the expression of the underlying genetic encephalopathy. That gets us to my last few slides. It's a new world. And this was the new world as it was in 1570. So I would argue that with a couple of exceptions, Really, genetic testing should be done on everyone, especially the young, to identify etiology. I mean, the recovery rate is over 40% if you do this. This informs pathophysiology. It allows you to plan personalized treatment to minimize or perhaps cure epilepsy severity and perhaps down the line reverse encephalopathy. That genetic, molecular, and pathway treatments are in our future, and that is really exciting to know that the neurologic diseases are eminently treatable. I would also argue, at least for those with focal epilepsy, especially in the young, that everyone should have a quality MRI at epilepsy onset, because you can identify pretty readily a large chunk of those children will benefit from early epilepsy surgery when medications fail them. And that is up to 10 to 50% of patients, which matches what is known epidemiologically in the expression of refractory epilepsy in those who are amenable to epilepsy surgery. You really need to have a high-quality epilepsy protocol for that. One should consider epilepsy surgery early, not as a last resort, and I think for many, epilepsy should be viewed as the treatment of choice, not of last resort. One must operate at a skilled pediatric epilepsy center with skilled hands and a skilled team. The epilepsy outcomes are better with earlier surgical intervention. New cognitive and behavioral deficits are unlikely. There is the prospect for developmental and social gains. There is plasticity for those with earlier surgery, especially before the age of 6, and you reduce, in the end, the risk of epilepsy mortality, which is far greater than the risk of the surgery. So with that, I would like to thank the many people who I have worked with over the years, and especially all the patients with whom it has been an honor to work over the last 30 years. These are just some of my colleagues at institutions such as NIH, Georgetown, and NIH, who have worked with us at many different levels with many different skill sets. I would also like to thank my collaborators for the perinatal stroke plasticity project, shown here from Georgetown, CHOP, and Children's. And finally, I would like to thank the members of our epilepsy team who are absolutely fabulous, and I would also like to thank those people who provided the data for the slides I gave today, and also for the members of the Pediatric Epilepsy Research Consortium and their funders who have made great strides in turning back pediatric epilepsy disorders. So with that, I end with this New Yorker slide. It is slaying the epilepsy dragon like that, says the young princess. So thank you very much for your kind attention, and I hope that you enjoy the rest of the meeting. Do we have target practice or do we flee?
I think you get to play.
Thank you, everybody.